Hello everyone, my name is Dr. Ashok Kumar. I welcome you all in the preparation of USMLE medical exams preparations through my lecture notes and MCQs, vignette based. We are going to learn today about the neoplasia. We will cover introduction and its nomenclature briefly. So let's understand what the neoplasia is. As the name says, neo means new, plasia means growth. It's a new growth, but uncontrolled, remember, right? So it's a new uncontrolled growth. A new uncontrolled growth of the cells, right? Therefore, it is a neoplasia, uncontrollable growth. Here we can see a mass. So actually, you can see this is the skin. Under the skin, there are lipocytes or fat cells. So they have undergone the reprogramming through mutations in the genes, which gave rise to unlimited, uncontrollable growth that these cells keep on multiplying, which are now on the bulge. Okay, good. There is another example, an oral cavity in which there are squamous cells which have undergone again mutations and now multiplying uncontrollably, right? Good. So it's giving rise to a tumor in the oral cavity. So this is uncontrolled growth that even persists even after the cessation of the stimulus which evoked it. Now, if a patient has developed a mass in the oral cavity that is seemingly, it is obvious that it is a tumor, actually it is a squamous cell carcinoma, if when we perform biopsy. Now, let's say this mass is incited by tobacco chewing by the patient. Now, after developing this cancer, now patient says, I won't chew tobacco or smoke tobacco, but still this tumor is not going to reverse because it persists now. Why it happened? Because of reprogramming, bad reprogramming through gene mutation. So what's the basic mechanism? It is actually the mutations in the genes. This is the heart of the development of the neoplasia, basic mechanism. So what actual genes are involved to lead to uncontrollable growth and neoplasia? There are certain a group of genes, right? Those are four actually gene groups are there. Proto-oncogenes, proto-oncogenes, they encode for the growth factors. So this is the cell, this is the nucleus. So here is the growth factor receptor. So actually growth factors or the receptors or downward signaling which ultimately push the cell into cell cycle to produce daughter cells and unlimited growth, right? So proto-oncogenes are actually the genes which code for growth factors to push the cell into cell cycle. So now the mutations can be in these proto-oncogenes to cause unlimited growth of the cells. Good. So this is one group. Second, tumor suppressor genes. Now, opposite to growth factors, there are suppressors. So, actually, these are the genes, products, proteins which stop the cell from entering into the cell cycle. But since suppressors have lost their function, let's say P53, RB genes, once what's their function? To stop the cell cycle, to arrest the cell cycle. But once the cell cycle is not under control, these genes have mutated, not functioning anymore. Cells will be keep on multiplying. So if there is a tumor again, the patient is prone to develop tumors. The third group, apoptotic genes, suicidal genes. Again, mutations, cells don't undergo apoptosis, even they consist of some mutations. Generally, there is a cell mechanism of DNA repair. But once, let's say fourth group, DNA repair. Again, if the mutations are existing in the DNA repair genes, genes cannot be repaired, which are mutated. Or If they cannot repair, they undergo apoptosis. Again, apoptotic genes don't function. They have undergone mutations. Those cells, bad cells, will survive with the mutations. Ultimately, the patient develops a tumor or a neoplasia, right? So these are the four classes: P, A, R for repair, T for tumor suppressor. So you can make an acronym PART. P for protoncogenes, A for apoptotic genes, R for repair genes, T for tumor suppressor genes. So any mutations in any of these groups can lead to development of a tumor. Good. So let's go ahead further. Components of a tumor or neoplasia or a neoplasm. These are very important. This is also very important to understand because in USMLE and in your medical exams, you can encounter this important question. Let's understand. Components of a tumor, like a normal tissue, tumors have two basic components we can see here. The functioning or parenchymal cells. For example, this is a glandular structure. This is a lumen. These are the cells lining the lumen. So this is a gland functional cells and they are supporting cells, stroma. We see here this is connective tissues, collagen, fibroblasts, blood vessels, stroma. You are very well familiar. So two components. Like normal tissues, these tumors have also two components. Functioning cells are proliferating or multiplying tumor cells and they are supportive stromal cells. These stromal cells support, the name says stroma, supportive. So they support actually by supplying nutrition through blood vessels and growth factors, etc. So proliferating cells, right? These are the proliferating cells of the tumors, which contain, in this case, the mutations in these proliferating cells and stromal supporting cells. So tumors rely on these supporting cells, fibroblasts, and collagen and supporting growth factors, etc. Stroma supporting this is that I have highlighted with the red lines, blood vessels and cells made up of connective tissues, blood vessels, and immune cells are also there, macrophages, lymphocytes. So these are actually blood vessels and connective tissue supportings for these tumor cells. And tumor cells highly rely on this support. Correct? Good. So now why we are interested in this stroma supportive? Because in certain tumors, what happens, especially epithelial type cancers, we will understand further what those are. So these stroma are secreted, produced in a huge amount, stimulated by these cancer cells. They stimulate their surrounding fibroblasts, stromal cells to produce a lot of collagen. And the tumors become firm because collagen means fibrous tissue, like scar formation. They become very hard tumors, right? And this is how the exams are encountered. In exams, you encounter certain questions. So this is of interest that when we have a lot of fibrous tissue in the tumor that we understood, that we term use desmoplasia or serous cancers. Serous like cirrhosis, fibrosis, desmo collagen, fibrous tissue, those stroma contain in these tumors. So desmoplasia, what we understood is an excessive stroma, that is, collagen stimulated by the parenchymal tumor cells, right? So these were the, for example, glands we can see here with the lumen surrounding cells, functioning tumor cells actual, which have stimulated the surrounding fibroblasts to produce a lot of fibrous collagenous fibrous tissues. Lot of you can see is eosinophilic pinkish material, like fibrous tissue formation a lot. So these are the cancer cells, and this is desmoplastic reaction. So question may be encountered in your exam. What are the important hallmark findings in this histopathological slide, or what is the important finding in this slide? So this is important finding. You may be given an arrow, like in this arrow, you can find this. So you have to select for desmoplastic reaction or desmoplasia, or you can be given a stain. Which stain is used to highlight or diagnose this case? So this is to stain desmoplasia, we go for trichrome Mason stain, TMS. Very important to remember, right? Most commonly, this excessive desmoplasia reaction is seen in invasive ductal carcinoma of the breast and other tissues, especially epithelial type cancers. This tumor becomes now stony hard or serous or fibrous, fibrosis containing cancer, right? Good. So let's interpret this vignette now. A 63-year-old woman presents with complaints of weight loss and progressive yellowing of the eyes. So a 63-year-old woman with presents with weight loss. Weight loss, very important for cancers and chronic diseases, tuberculosis on top, differential diagnosis. Let's go ahead further. What's going on in this case? And progressive yellowing of the eyes. Yellowing of the eyes, a thing is coming in your mind that is related to the liver or hemolytic anemias, for example, right? She reports 40 pack year smoking history. She's a smoker and regular alcohol drinker for last 25 years. On physical examination, findings include scleral icterus, that's yellow discoloration of the eyes, a palpable gallbladder. Gallbladder is also palpable. Good. A CT scan of the abdomen reveals a 3 by 3 mass in the pancreatic region. So there's a mass in the pancreas. Infiltrating, further attacking, and firmly attached to the second part of the duodenum. And you can see now pancreatic mass has infiltrated, attacked the duodenal second part where ampulla of Vater opens. Ampulla of Vater where the duct drains, right? Therefore, this pancreatic mass, if you think critically, has occluded the ampulla of Vater so that there is no further drainage of the gallbladder contents from liver. Therefore, there is backstasis of these chemicals and bilirubin. Therefore, patient is developed jaundice, right? So how this chain is connected? Good. What is the prominent finding indicated by an arrow in this image, which caused the firm attachment of the mass to the duodenum? So let's see. The question is asking you about this arrow, what this finding is. So you have to see further. So these are gland-like structures. You can see this lumen, these are surrounding cells, lot of hyperchromatic, dense, bigger nuclei containing cells. You can see purple color dotted cells. And this is a lot of, what is this? Stroma, right? A lot of stroma is produced. So the question is asking, what is this finding? A, deposition of excessive collagenous tissue, or deposition of excessive amyloid, presence of excessive metaplastic cells, proliferation of smooth muscle cells, or peptides produced by endocrine cells. Now you can see easily, we understood it is option A, deposition of excessive collagenous tissue. This excessive collagen, eosinophilic fibrous tissue produced by the fibroblasts in the stroma, is stimulated mainly by these cancer cells of the pancreas, parenchymal cells, proliferating cancer cells. Okay, sometimes you may be asked the question, which cells caused the formation of this finding indicated by arrow? Which cells collagen is produced by you know that, fibroblasts. Correct. And if I ask you further, which stain we understood we would use to stain this finding? Trichrome Mason stain, TMS. Good. Now, let's understand tumor classification. Tumor classification, we classify the tumors on the basis of cell of origin, that is epithelial, right? Epithelial cells. For example, columnar epithelial cells, squamous cells, transitional cells, hepatocytes, these renal cells, these come under the heading of epithelial cells. Other cells are mesenchymal cells, which include connective tissues, for example, fibroblasts, in connective tissue, collagen forming fibroblasts. Others are fat cells, lipocytes, muscle cells, smooth and striated muscle cells, cartilages, bones, blood vessels, and blood itself. These types of cells come under mesenchymal cell origin. Why we need to understand? This is very important so that we can name the type of the tumor so that patients can be well diagnosed and well treated. Epithelial cell type tumors have different treatment. Mesenchymal cell type tumors have different treatments. So we need to know which kind of patient's tumor is. It is epithelial, we will treat accordingly. If it is mesenchymal, we will treat differently, right? Good. So, on clinical behavior, we classify these both tumors further, epithelial or mesenchymal, into benign and malignant. Benign are, see, the name says polite, gentle, so they do not cause death until unless they are at the critical location, for example, in the brain. Otherwise, benign tumors are localized, they remain local, they do not disseminate, spread to further sites. For example, famous example, lipoma. It remains in that area. And so this is a lipoma, for example, lipocytes, lipid cells, fat cells, benign tumor that is easily treatable. It doesn't spread. It is just local, growing on the local site uncontrollably, further increasing, but not going to distant sites, right? So this is a benign, and these benign tumors have mature cells. Mature cells means they have small nucleus. They are mature cells. They resemble like normal tissues. Normal nuclear NC ratio, cytoplasmic ratio is 1:4, right? Of any benign tumor, generally we say they have mature cells. This point is very important to remember. Again, you may be asked in your questions, exam questions, right? So a patient having a mass, having nuclear ratio 1:4 or mature cells, then you can think of benign tumor. So you can see these are fat cells with tiny nucleus in the periphery, tiny nucleus. So mature cells with small nucleus. On the other hand, malignant tumors, those metastasize to distant sites. They attack the surrounding tissues and further spread to distant sites to invade other organs. So same example of the same type, for example, we take liposarcoma. But this liposarcoma further invades the distant sites. Their cells are immature because they are quickly multiplying. Their nucleus is very big. They have more mutations. NC ratio is increased. NC ratio, nuclear cytoplasmic. So nucleus becomes bigger. If you see this fat cell, they have very tiny nucleus. But if you see this fat cells, they have very big nucleus, prominent. So their NC ratio, nuclear cytoplasmic ratio is increased. So remember, very important point, immature cells with increased NC ratio indicate a malignant tumor. A lethal, malignant means lethal, that can kill. So what we understood, two type of tumors, mainly epithelial and mesenchymal. Epithelial, mesenchymal, further they may be benign or malignant, very simple, right? So now let's interpret this vignette. A 25-year-old woman in good health attends a routine physical checkup. She has no history of smoking or drug use. During the examination, a painless, well-defined, firm, rubbery, and mobile mass is detected in her right breast. Okay, right breast. There is a painless, mobile, moving mass. This is also very important finding. Remember why I'm saying mobile. In this case it is shown. Mostly you may think of mobile means it can move, that means it has not attacked, invaded the surrounding tissues. So it seems from the medical examination to be a benign mass, but we don't know yet. We have to perform biopsy and further, but let's understand further. Once you find firm mass attached, it doesn't move, then you have suspicious already from the history and the examination without undergoing further investigations, yes, it may be malignant, or maybe other mass, some inflammation, etc. Let's see, there is no evidence of axillary lymph node enlargement. So it means it doesn't seem that cancer cells have or tumor cells have further metastasized or somewhere. So far, let's understand the excised mass is analyzed and microscopic evaluation shows mature cells with a normal NC ratio. What do you think? What is the most likely diagnosis in this patient? Now, just asking most likely diagnosis. Is it a malignant lesion? It's a benign lesion? Abscess due to acute bacterial infection? Metastatic lesion? What do you think? It is a B, benign lesion. Why? Because of mature cells with the normal NC ratio. Very important finding. Please remember, right? So it's a benign. Malignant, if it were malignant, the NC ratio would have been disturbed. Cells would be immature. If it is abscess due to bacterial infection, this is another case, this is another case. If it is a bacterial infection, it will be painful, acute, painful. Patient will have fever, right? And neutrophils, acute cells infiltration, and redness in the breast, tender on palpation. Here it is not the case. Metastatic lesion, if it's a metastatic lesion, again, the primary site will be different and it will be firmly attached. So it is obvious that patient is, and if it is a metastatic lesion, again NC ratio will be disturbed because it is a malignant. So no, the correct answer right now it is benign lesion. Good. So now let's understand nomenclature, how we give the name to these tumors, to epithelial and mesenchymal. So let's understand first mesenchymal, quite easy. What we do actually, we attach oma suffix oma to the cell name. For example, we have lipocytes. So what we do, we attach suffix oma. Lip site we remove, lipoma. Correct? So that is a name says it's a benign because oma is attached to the cell name. Lipoma. Now you understand? Lipoma means benign lipocyte tumor. What if it is a malignant? We attach sarcoma, not oma, but sarcoma to the cell name. Same way we see lipo, oma we don't attach, sarcoma, liposarcoma. Clear? Very good. Once you see liposarcoma, you say sarcoma, it is a malignant killer, liposarcoma. Malignant tumor of the lipocytes, liposarcoma. Good. Epithelial cell tumors have also more or less some similar. Again, we attach oma as a suffix, but in epithelial tumors, we take their shape appearance also importantly is attached to the cell name. For example, we have thyroid gland. Thyroid gland has epithelial cells, right? So oma is there, it's a benign, it's a benign tumor, we understand, but we take the shape, adeno. Adeno means gland or gland-like. So gland plus oma, because how they appear, shape and shape appearance. In microscopy, we see, so this is a gland. It's a lumen surrounded by these epithelial cells, right? Follicles, thyroid follicles, which are actually glands with secretions and surrounding cells. So this is a gland. Other tumors can be gland-like or it's a gland clear cut. So we say it is adeno. Adeno means gland. They look like a gland. Then it's a adeno. Oma means benign. Shape plus oma. So it is a adenoma. Thyroid adenoma. Follicular adenoma. Thyroid adenoma. Is it clear, right? Good. So here we attach also the shape. Papilloma. Papil means finger-like. Oma is a benign. Finger-like, for example, warts. which are common. But when you say in medical terminology, warts are excessive growth, uncontrolled, right? So, but when we say how to categorize, these are benign lesions, benign tumors. So, papil means finger like, oma, because they have warts, have small finger like. Macroscopically as well as microscopically, if you see, the cells will be arranged in finger like arrangements. Cells will be lined on these fingers, the cells. So we name them. Papil means finger, oma means benign, finger like benign lesions. Good. So now let's further move. That was a benign epithelial tumor. Now malignant. Here we attach carcinoma plus shape appearance. For mesenchymal, what we attached here? Sarcoma. But for epithelial, we attached carcinoma. But again, we attach shape. For example, again, let's take the same example. Adeno, it's a gland. For example, it's a thyroid. Now, thyroid, malignant tumor. What we say? Thyroid, adeno gland like or gland carcinoma, malignant. Carcinoma is a malignant. So, adeno gland carcinoma is attached, not oma. Adenocarcinoma, gland-like appearance, that's malignant carcinoma. Papillary carcinoma, finger-like, papilloma not, but here papillary carcinoma, that indicates malignant, right? And some other tumors of the epithelial origin, especially malignant ones, where we don't attach the shape, just we attach carcinoma. That is, for example, squamous cell carcinoma, hepatocellular hepatocytes carcinoma. It is very simple, as simple like we understood up there in the sarcoma. Just you attach liposarcoma, straight, no appearance. Lipocytes, malignant tumor sarcoma. Similar way, squamous cells, malignant epithelial cells, carcinoma. Very simple, right? So I hope this clarifies. In simple words, for benign epithelial and malignant, both tumors, benign we attach oma for both epithelial and mesenchymal, oma. But for epithelial, benign, we understood oma. For malignant, we attached carcinoma. And for mesenchymal malignant, we attached, what we attached? Sarcoma. Now, exceptions are there, remember, there are certain exceptions. Malignant tumors with oma. Wow. Please remember this also, very important. Examples. Lymphoma. These are the blood cell tumors which are having oma but malignant. Remember, myeloma, plasma cells tumors. Again, malignant. Hepatoma or hepatocellular carcinoma. Hepatocellular carcinoma, the other name is hepatoma. Don't mistake that it is a benign. No, it is hepatocyte with oma, but it's a malignant. It's a killer. Melanoma, melanocyte tumors. Again, these are malignant. Seminoma, nephroblastoma, mesothelioma. These are exceptions. Please remember this. Memorize this. This slide is very, very important. Again, that's frequently encountered questions in the exams. Again, immunohistochemical stains, the cell types, and which stain or antibodies we use. For example, if you are given a mass, cells cannot be recognized if those are epithelial or mesenchymal, confusing cells. Cells have lost their shape. Those are cancerous cells. But you want to know if it is epithelial or mesenchymal tumor because once cells multiply, they metastasize. For example, this is a cell, cancerous cell. This is other cancer cells with bigger nucleus. We don't know if it is epithelial or mesenchymal. How can we target therapy. So we need to understand which kind of cell it is. It is epithelial or mesenchymal. First, we understand this one. So we need to stain the cells, correct? To properly treat the patient and solve the exam questions, right? So in this case, for epithelial cells, which stain is positive? Cytokeratin. Must to memorize. Cytokeratin. Once you stain these cells which stain with cytokeratin, you will say, it is an epithelial cell tumor. But if the cells stain for the vimentin, not cytokeratin, but vimentin, then you will say, this is not epithelial. For example, it is a mesenchymal tumor. Mesenchymal tumor, right? Vimentin for mesenchymal. There, mesenchymal contains what we understood many types of cells. Connective tissues, fibroblasts, skeletal muscle cells, smooth muscle cells, cartilages, endothelial lining cells on the blood vessels and vessels, leukocytes, renal tubular cells. These are actually the stromal cells, mesenchymal cells, and stromal cells and other cells. So mesenchymal cells go for vimentin, epithelial cells go for cytokeratin. Now mesenchymal cells go for vimentin. Further, how to say, let's say it's mesenchymal cell we understood for vimentin. Mesenchymal staining can be positive in fibroblasts, skeletal muscles, cartilages. Further, if you want to shrink it down further, for muscle cells only, that will be desmin. Only for the muscle cells, striated and smooth muscle cells. So smooth muscle cells and striated muscle cells will stain positive for desmin as well as vimentin. But remaining others, lipocytes, fibroblasts, blood vessels, endothelials, cartilages, they will stain only for vimentin, not for the desmin. Desmin is only reserved for the muscles, remember. So these three stains are must to memorize, must to memorize. You can never forget it, please. Right? Let's go ahead further now. With this, let's interpret this vignette. A 46-year-old woman presents with intermittent vaginal spotting for the past 1.5 months. Intermittent vaginal bleeding spots. A 46-year-old woman. Her obstetric history is unremarkable and previous annual pap smear results were normal. Okay, pap smear is normal, good. Following an ultrasound evaluation and a uterine biopsy, she is diagnosed with endometrial carcinoma. Endometrial carcinoma. Which of the following stain would best confirm this diagnosis? You want to further confirm it is if it is really endometrial, it may be myometrium, it may be perimetrium, it may be other tumor. So how do you know if it is really endometrial carcinoma? Which of the following stain? Is it cytokeratin? Is it anti-CD3? Is it vimentin? Is it desmin? Or it is HND, hematoxylin and eosin stain? So what's the correct answer? You know that? It is a cytokeratin. Why is that? Because endometrial carcinoma, it's endometrial. If it is positive for cytokeratin, because why? It is positive for cytokeratin because the tumor is in the endometrium. Endometrium is lined by what cells? Columnar epithelial cells, right? Endometrium lined by the, you know that, normal histology. Columnar, elongated columnar epithelial cells. So it is actually going to stand for cytokeratin. If the history says the mass is seen in the myometrium, then it means muscle cells. So then you can select for the specific desmin. But here the tumor is in the endometrium, therefore you are saying it is positive for cytokeratin. Correct? Good. Anti-CD3 stain is not fitting here because CD3 is the marker for the T lymphocytes. Vimentin, other mesenchymal tumors, right? We understood already in the previous chart. Desmin is for the muscles, not for the endometrial or epithelial cells. These are epithelial cells, right? And HND stent is not a specific stent, it's a common stent, a standard gold standard stent that stents all epithelial and mesenchymal cells. So a specific stent is a cytokeratin that stents these endometrial epithelial cells. Good. So these are the book references. Okay, guys, I hope you understood. You can contact me at my given information in this link, YouTube. Thank you very much. Have a great day. See you next time soon.